Good morning, good afternoon, good evening to all our colleagues. I am Shiv Sarin, and on behalf of the APASL and this program, it's a great honor for me to, invite and see all the editors and colleagues from the Journal of Hepatology, which is right now the best journal rated in the world in the field of hepatology. The idea of having exclusive publications which are the best in the field of hepatology in 2020 came up, and I approached the editor-in-chief, Professor Paolo Angeli, who kindly agreed for this, and he and his team has consented, and they picked up a few topics which are of relevance, and they are the best experts. The idea was, how do we come across what we have not read or we have not understood? And as a student, I want to learn, because many topics I have missed in JHEP, and they are very well explained. APASL's webinar series have been very popular. Generally, the attendance goes to 150 to 200, sometimes to 700 also. And we do hope that today we will have a wide audience. And also these lectures, which the seminars will go for 2.5 hours, will be heard by students, faculty, and researchers across Asia and maybe across Europe also. I have my colleague, Professor Omata, a very eminent hepatologist, and he's also amongst the moderators today. He is with us, and both of us have the pleasure of working in Hepatology International. We have 4 best moderators here. I'm not going to repeat, and a series of eminent experts who are there for the sessions. Masao, if you would like to say something now, and then on behalf of APASL, we'll hand over to Paolo. You are mute, Masao. In the interest of time, I would request now to start the session, and I would ask Paolo to take the lead, and Dr. Omata will certainly speak during the sessions. We hand over to Editor-in-Chief of JHEP, Paolo, for a very nice and hopefully very educative sessions. Paolo.
Well, thank you very much, Shiv, and thank you to all the committee of APASL for giving us the opportunity to show the best papers we selected in specific areas during the last year. Let me introduce briefly the journal, showing that our mission is to continue to build science and to disseminate knowledge as it has been done during the past years. But we want also to increase the geopolitical influence of the journal and the interaction of the journal with all the community, not only researchers, physicians, but also general public, patients associations, politicians, and decision makers in healthcare, because we learn from the lesson of DAAs in the treatment of Hep C that the influence of the public is crucial to allow access to an effective treatment. Of course, our strategy to get this result is a secret of the team, but I can show you what I asked to my editors and what I got from all them. To be open in mind and inclusive, to develop a teamwork, to be excellent, to be accountable, but overall to be fair and right. And again, I got all this from my editors, and I want to thank all them. So I'm more confident now than when I started that we will be able to progress in continuity with the Journal of Hep. We are moving from a very high level our impact factor is higher than 20, the highest among the journal in hepatology. And the secret is that we have published high quality paper who are receiving an increasing number of citations over the years. Let me show you some figures about the journal during the last year. We have received an increased number of original papers. But in spite of this, the performance of the editorial team was excellent. We were able to reduce the decision time, the turnaround time. We are able to reduce the revision rate and the acceptance rate low to 8 or 7%. And I want to spend some words on this because it is not easy to deal with an acceptance rate of 6%. So I want to thank, first of all the authors for sending us so high quality papers. This is the real secret of the journal success. And I want to apologize to them that sometimes the final decision on acceptance is only based on priorities. And so I think that the final decision cannot be easily understood and accepted sometimes. But believe me, these are the hardest decisions that we can take in the editorial team. And again, the editorial team is doing an excellent, crucial job. What about the geopolitical influence of the journal? We are receiving more and more papers from US, but also from China, from South Korea, from India. And you know, 3 Asian countries, China, South Korea, and others are among the top 10 countries for accepted paper in 2020. We want to do better next year. What about the influence of the COVID-19 on the editorial work? You know, the original paper with COVID-19 in the title accounted only for 25% of the increase in the original paper we received during this year. We were very, very selective in the evaluation process of the original COVID-19 paper. At the end, we only accepted 6 original articles, 2 reviews, and 20 letters to the editors. But we were very lucky. We did not find ourselves into trouble like the New England, like the Lancet. On the contrary, as you can see, the accepted paper with COVID-19 in the title are among the top 20 articles accepted in 2020 with the highest number of citations. Well, let me introduce now the program, and I want to thank all my editors to be here live. So Patrizia will speak about liver transplantation, Vlad about NAFLD, Stefan about liver cancer, Ed about viral hepatitis, and Matias about basic science. But I won't leave you showing the cover of the issue of December of the Journal of Hepatology that is dedicated to the winners of the Nobel Prize. They made it possible to defeat a very dangerous virus for humanity. Now we are facing another very dangerous virus, but I'm sure that we will be able to defeat it next year. And this is my wish for you, for the world, for the upcoming Christmas holidays. Thank you very much again for the kind invitation.
Maybe Paolo, you need to invite as moderator or Masao to the next speaker. Masao, could you?
So, I think that Professor Massimo Colombo
Okay.
could introduce the program.
Okay, can you show me the program? It doesn't appear on the screen.
Izumi, can you show the program on the screen? I can read out. The first talk is by Dr. Patrizia Burra on critical care, hepatology, and liver transplant.
Okay, it is a great pleasure because Patrizia is a well-known expert in the field. He has been actively engaged in a number of educational activities strictly connected with liver transplantation. And in Italy, she's leading a number of initiatives aimed to improve our practice in this field. I think in the very last years, the field is in reach of a number of new interventions. And I think that Patrizia has the right expertise to inform you about, and we are all indebted with her for what she's going to tell us today. Patrizia, great pleasure to have you here with us.
Non ti sentiamo, Patrizia.
No, as I said, I would like to thank very much Professor Colombo for the nice introduction. To share the slides, I think you have to remove your slides, otherwise I cannot share mine. Paolo, you have to stop sharing your slides. And then I should. Not yet. Paolo, you need to stop sharing because we are managing. Okay, that's fine. And now I should be able to share mine. No. Mm-hmm. Can you see the slides?
Yes, we can.
Okay.
Yeah,
Sorry for that. So, as I said, thank you very much to all APASL group for the invitation, and as I said, thank you to Massimo for the introduction. So it's quite true that just to give you a little bit of an overview, I know that you don't need it. All of you are so expert in the field, we don't need to have this picture, but just to summarize that when we talk about the end-stage liver disease and liver transplantation, we discuss about the role of liver disease on the acute decompensation of cirrhosis, but also in acute and chronic liver failure. It is quite, despite it's an old story, it's really becoming more and more interesting in terms of publication, including all the different complications that we can have. And in fact, just let me only present two old papers published on JHEP, just to show the story about that, which introduced the most recent indication to perform liver transplantation, which was considered to be futile in the past for the compensation of cirrhosis for acute and chronic. And Rajiv Jalang, the previous editor-in-chief of JHEP, and Massimo was the previous editor. The acute and chronic liver failure is definitely defined as a different syndrome, which is different from the chronic decompensation, since an acute event would occur to change really the natural history of the patient. And usually the events, they are more the complicated the picture are the development of acute kidney injury, the bleeding, and the infection. If we just like, again, for the story of the publication JHEP, this is from our editor-in-chief, where he stratified for the ACI the three different stages, very helpful in order to predict what was the mortality. And another paper in JHEP from his group show, in fact, that the mortality for ACI when you enter the hospital with ACI stage 2 and 3 is in between 60 to 65%. But now coming, what are the papers that are a little bit in line, let's say, with what we are discussing. First of all, I selected the one from Lai and her US group, and she is very well known on the evaluation of frailty. I consider this as a complication of cirrhosis that can interfere with maintenance of the patient on the waiting list. So in this paper, the authors wanted to evaluate the changes in frailty, not as a static evaluation, but the evaluation over time. And they wanted to see if that evaluation was able to predict that or the listing for too advanced and stage liver disease on the waiting list. This paper was selected and was selected by JHEP because he really reported more than 1,000 prospective evaluation in outpatient cases, and they were all with cirrhosis without hepatocellular carcinoma in order to avoid the confounding factors of HCC. They were all listed for liver transplantation at 8 US centers, and all of them underwent outpatient, so ambulatory longitudinal frailty testing. And the authors then created an internal model to predict how much frailty over time for at least three months, together with age, gender, sodium meld, ascites, and hepatic encephalopathy would really be useful for the testing. And okay, and what they show after a median follow-up of 11 months, that 20% of the patients that were listed, this cohort of patients, they actually overall they died or they were delisted, so they were not suitable anymore for liver transplantation. And they also evaluated that the cumulative incidence of that of the listing increased by worsening frailty over time. And when they evaluated the 3 months, the over 3 months evaluation, it was associated surely with a twofold increased risk of that of the listing. So I think my comment is that we know that changes in frailty are associated with poor outcome, but in this case, this large study confirmed that it is independent by baseline classical terms that we use, such as the MELD sodium. So the MELD sodium doesn't really represent, as we'll see in other different situations, the risk of a delisting of that in patient with cirrhosis. And surely the clear message is that probably we should organize our outpatient clinic in order to evaluate longitudinal measurement of frailty and organize an interventional work aimed at reversing this complication in a liver transplant patient on the waiting list. The other, sorry again. Okay, the other paper, there is something. The other paper that I selected, this is, we are moving into a little bit of acute and chronic liver failure, is the decompensation in the field of decompensation of alcohol-associated liver disease. This is a paper from Dr. Degree. It was published this year. And the background is that there are not so many data on the long-term outcome of patients who start with alcohol-related liver disease and then they experience a decompensation. Actually, there is a discussion ongoing in Europe, in particular in Europe, about the nomenclature, if we can consider the decompensation of patients with alcohol-related liver disease a decompensation or acute and chronic liver failure due to alcohol, or an acute and chronic liver failure caused by some events on the top of alcohol-related cirrhosis. So that is his ongoing discussion. But coming to this study, this is a retrospective study. It was based on a 2 European center cohort, and they evaluated the patient admitted for liver decompensation. Interesting enough, they had biopsy-proven alcohol-associated steatohepatitis, and all of them were selected based on the MEDRI discriminant function that you know lower than 32. And the authors evaluated the 5-year survival in 121 patients who were admitted for complication of cirrhosis, such as encephalopathy, ascites, jaundice, and 84 of them had already cirrhosis. The author reported that during the follow-up, 30% of the patients remained abstinent. So what this group demonstrates is that, respectively, the survival during the first 2 years, 1, 6, 12, and 24 months, were very good, 97, 90, 81, 70%. And then at 5 years, it was 51%. And the majority of that, 80% of them, were due to the liver decompensation. When the author performed the multivariate analysis, encephalopathy, a baseline, and alcohol abstinence were the two most useful features to predict the 5-year survival. And so the interesting, I found this interesting stratification, let's say, of the patient, very easy actually to think, were to stratify the patient into two categories: the ones that had the encephalopathy and at baseline, and the ones that didn't have encephalopathy. As you can see, the 5-year survival was significantly different, 30% in the patient with encephalopathy baseline comparing to 60% survival of patients without encephalopathy. Another stratification was done on the abstinence and non-abstinence of those patients. And again, a very striking difference in terms of 5-year survival, 41% in the patient that was still drinking and 75% still quite good in the patient not drinking. So the comment is that the mortality of patients who develop acute decompensation of alcohol-related liver disease is definitely still too high. Therefore, we have to work on that, proposing new treatment strategy, including measures to prevent encephalopathy, and of course, as expected, as we know, to obtain the abstinence. Another paper, again on the complication of cirrhosis in terms of the development of acute or chronic liver failure, is going to be published very soon in JHEP. This is from Dr. Kuma. So this is related to the role of the deterioration of acute with the deterioration of cirrhosis due to varicose bleeding episodes. And so the occurrence of acute and chronic liver failure, as alluded to before, is one of the triggers, together with the renal injury and together with the infection of the development of acute and chronic liver failure. In fact, this is a study where they wanted to evaluate the role of development of a CLF on a 42-day and 1-year mortality in those patients, and to evaluate if that was a change in case of an intervention with the tips. So the aims of the study were to define the risk of that of acute and chronic liver failure induced by the failure to control the bleeding, and then to see if the tips improve the survival. So they used an ICU registry. They obtained data from 174 patients, and the rescue tips was defined according to the Baveno 6, which means that you have to perform tips within 72 hours after 2 failures of endoscopy. And what they found, there were 119 patients with a CLF. They compare with the 57 patients with a decompensation, and they found that 42 days and 1 year mortality was much higher in a CLF compared to the patient with decompensation. In a CLF was 42 days, 48%, and 1 year, 61%. Then they evaluated the tips inserted in 78 patients, 21 with decompensation and 57 with a CLF. And they found that in a CLF patient, the rescue tips was an independent factor for a good prognosis for the 42 days mortality. However, in the other group, that didn't work in the mortality for the acute decompensation. So I think my comment is that the CLF related to failure to control treatment of various bleeding contributes surely to the definition of the risk of both short-term mortality, but also mid-long-term mortality, but rescue tips does improve both of them. And the last one paper is on liver transplantation, actually on the waiting list and the impact on liver transplantation. As you can see, there are not so many papers on CLF and liver transplantation, because until a few years ago, it was really a contraindication to perform or to actually to propose a liver transplantation in a CLF3 with the risk to perform a futile liver transplantation. This is a paper that is, I'm just mention also the previous paper, because they are one the consequence of the other one in terms of a group of patients. Vinail Sundaram together with Rajiv Jalan, they selected a patient with a CLF and showing that even if we do list them for liver transplantation, the scores that we have available, the MELD, but also the MELD sodium, unfortunately, do not really reflect exactly the severity of liver disease. So in this case, they have lower priority and higher waitlist mortality. A good data that came from these papers is that once you have the patient that had been listed with a CLF3, but at the time of transplantation, it improved being a CLF 0, 1, or 2, at least in this case, the 1-year survival increased from 82 to 88%, and in particular, that was seen in younger recipients. Thank you very much for your attention.
Thank you very much, Patrizia. I think that your presentation is going to be discussed cumulatively. Am I correct, Shiv? At the end of the presentation. So I think that we can move forward to the next presentation, who is going to be given by Professor Vlad Ratziu, who is a KOL in the area of NAFLD. He is also a pioneer trialist in this area, and everyone is expecting from him good news with respect to treatment improvements. Vlad?
Hello, thank you, Massimo, for the very nice introduction. I will try to share my screen, and I hope I will be successful. Do you see it?
Good.
Yes?
Yeah.
Yes,
Yeah.
we do.
It works.
Okay.
It works.
It works well. So, first of all, I apologize for the quality of the video. I forgot at work my camera, my webcam, and I'm gonna buy one to have one at home if this COVID thing continues. But it doesn't matter. What matters is that you see my slides. So what I would try to do is to cover only the 2020 year, which was indeed, I believe, a great year for the journal. And I will not go into detail of a few papers, but I will just try to cover the big themes that we tried to publish on, and which are basically centered on NAFLD, on autoimmune and genetic liver diseases, and also on drug-induced liver injury. And those are the covers from the main issues that were published in 2020. So the first thing I would like to say is that we're, of course, going through an era of therapeutic trials in NASH, and I think it is important that most therapeutic trials, which now are becoming larger phase trials with a lot of patients included, be published in top journals if they provide important advances in the field, which doesn't necessarily mean positive results. And this is a collection of some of the important papers in terms of NASH trials that were published in the journal. I'm going to go very fast with some of them. Just to point out some of the things that we're interested in. Of course, results, efficacy results are important, but not necessarily only results. For instance, we are very interested in drugs that explore new mechanisms of action or that uncover pharmacological targets that are original, novel, and that can be of interest in treatment of this disease. One example of that was with this new insulin sensitizer, which is like a glitazone-like, but without most of the side effects of glitazones. And this was published this year by, it is an American study that tested this new insulin sensitizer, which basically is an inhibitor of a new target in NASH, which is the mitochondrial pyruvate carrier. This is the carrier that shuffles through the mitochondrial membrane pyruvate. Pyruvate comes from amino acids and also from glucose once into the mitochondria. it gives, through the chemical reaction chains, birth to acetyl-CoA, which then will induce de novo lipogenesis. And it also will increase the production of glucose, so gluconeogenesis, two important features of NASH. By doing so and making mitochondria work, it will also increase production of reactive oxygen species. So this particular inhibitor was engineered to impact on the mitochondrial pyruvate carrier and therefore be devoid of all the bad side effects that occur when you activate PPAR gamma. And this study was a very large randomized control study, 290 patients involved, placebo, 2 doses, and that detailed the histological results. So unfortunately, overall, for different reasons that are well explained, this was not efficient in improving histology, but it did identify subgroups of patients in post-hoc analysis that might benefit from that. Another example of an innovative trial that JHEP published actually a series of papers on is a pan-caspase inhibitor, Emricasan, which has been in development for many years now. And this is the first study that was published, again, a large international study in NASH. You can see 320 patients, 2 doses versus placebo, which tested the effects of Emricasan on histology again. And unfortunately, although there is a very strong rationale for this drug to be improving different aspects of NASH, the histological results were not positive, and this is the study that was published in pre-cirrhotic NASH. But I think that even if the results are negative, it is very important that these trials be published, both because we need to better understand and better improve trial design, but also understand the discrepancy between the preclinical data and the clinical data with some of the drugs that we're using today. The second in this series was a paper that studied specifically the impact of Emricasan in patients with cirrhosis, histologically defined, with clinically significant portal hypertension. Again, a very large study, 260 patients, placebo in 3 arms. Everybody had central reading of the hepatic venous pressure gradient. And unfortunately, despite, again, some very encouraging initial data in clinical trials, the drug was not able to reduce the hepatic venous pressure gradient, which tells you about the importance to always try to confirm small phase 2A trials in larger trials, and most of the time we have surprises. And please be tuned, because in next year we'll publish the last of this series here, Emricasan in decompensated cirrhosis. This trial is in press now. It will be published probably in the February 2021 issue. So a nice collection of articles on a pan-caspase inhibitor and one of the drugs that was very promising. Another paper we're very proud of having published is the very large phase 3 trial of selonsertib, which is an ASK1 inhibitor, apoptosis signaling kinase 1 inhibitor. Those were 2 trials that were condensed in 1 paper published in our journal, very large international studies, 800 patients for one, 880 patients for the other. One was pre-cirrhotic, the other one was cirrhotic trial. And this study has been commented upon a lot, presented at AASLD as a late breaker. And unfortunately, the initial results, which were positive results published in Hepatology from a small phase 2 trial, were not confirmed in this large phase 3 trials here. And again, it is very important to be aware of that, to understand the trial design. However, though, this study is extremely important because it provides some very useful information about the non-invasive markers and how these predict histological response. So this is very, and you'll read that in there, very important data for the future, because based on these databases, we now better understand whether and how non-invasive markers predict the histological response, with the hope that someday we will replace liver biopsy. This study was accompanied by a very nice editorial that explains the reasons why many NASH trials fails, particularly in phase 3, and how we can improve on phase 2 trials so that the predictability of phase 3 trials improves. Another very interesting trial that falls in the category of those that we like because they explore mechanism of action that makes sense in NASH And then we try to, with an open mind, understand whether this translates into clinical benefit. This international study, again, it was mostly a US and UK study that looked at volixibat, which is actually an apical sodium-dependent bile acid transporter. So basically what happens, and you can see a very detailed explanation on the right part of this cartoon here, of this slide here in this cartoon, which comes from a top review from experts in the field, Ulrich Boyers, Michael Trauner, Raoul Poupon, which very nicely explains that if you want to block bile acid production, either you block synthesis with an FXR agonist, or you block reabsorption in the ileum with an ASBT inhibitor, which is what volixibat is. And in both cases, you have a similar depletion of the bile acid pool. And you know that there's a lot of data now associating bile acid toxicity with Nash. And this study is very interesting because it tested whether that paradigm actually translates into clinical benefit. Almost 200 patients, randomized placebo in 3 doses. Not all of them had a liver biopsy because an histological interim analysis was performed and it did not show an improvement. But what is important is that the study did demonstrate target engagement in the sense that there was an increase in C4 and a decrease in circulating bile acids, as you can see here on the slides. And despite that, there was no improvement in histology, which means that we have to work harder to better target the right pathways that can be involved in progressive disease in NASH. So all those trials were very exciting, but we also tried to give prime time to papers that help the whole environment of drug development. And I will explain to you immediately what that means. So this is a very important paper that tries to understand if we have a closer look at how we read liver biopsies, if our tools are perfect or imperfect, and in the latter case, if they can have an impact on the negative results of some of the trials that I've presented earlier. And this is a fantastic paper that you should look at because actually it comes from the earlier trial of the mitochondrial pyruvate carrier inhibitor that I've shown you first. And basically the slides were read again by the same pathologist that was the original pathologist, but also by 2 other pathologists which were part of this secondary study. And the paper basically explains the discordances and the concordance between the readers and between different strategies to read the slides in a clinical trial, because you can read them several ways. And the overall result is that there is a tremendous variability, both in terms of temporal variability, intra-observer, but also in terms of inter-observer variability. And the authors make very smart modeling on how this variability can impact actually the result of the trial and how they can negate even positive results with drugs that are moderately active. But because we want to really create a debate around these issues, we asked the opposite point of view, which is the pathologist's points of view, to give us to provide us with their input on and their analysis of these results. And this is how we have a very nice editorial from Elizabeth Brunt, which details the point of view in favor of histology and trying to understand whether there are ways we can improve that. Another very important paper, again, in the environment of clinical trial development is an official paper that comes from the Liver Forum, an international multi-stakeholder consortium that publishes a series of papers on NASH trials. And this one in particular, which was published in our journal, talks about the very important aspect of how do you standardize diet and exercise when you do these clinical trials for pharmacological agents, because this can have an important impact, particularly on the placebo response rate. And this is a sort of a review, expert recommendation, position paper that details here, very practically speaking, what is recommended by this very large international group when you want to conduct a NASH trial and how you should fine-tune these recommendations on not on the drug side, but on the overall management side, so that you can have comparable groups. And you can see there's very precise recommendations that are given in this article. Another aspect that I would like to explain is that, okay, we're trying to publish the important clinical trials in NASH, but we also give a lot of room to high-level basic studies that detail the preclinical data, the basic rationale that bring these molecules to the human trials phase of their development. And these are just two examples. One is from the Gilead scientist, Jamie Bates, first author, that look at what can be the anti-fibrotic mechanism of firzocostat, which is an ACC, acetyl-CoA carboxylase inhibitor in development, is one of the main drugs that Gilead has for NASH. And this trial, this study in the animal details the impact the ACC inhibition can have on the metabolic reprogramming of stellate cells, and how this impact in an inhibition of their transdifferentiation into myofibroblasts and on collagen synthesis by these cells. The second example comes from Frank Takia's group, which is co-editor at the Journal of Hepatology, and he looks at lanifibranor. This is another agent that has shown very positive results in a phase 2b trial, which were presented as a late breaker at the latest AASLD meeting. And it is a pan-PPAR inhibitor, alpha, delta, and gamma. And this study here looks at the different improvements that this pan-PPAR inhibitor has on the aspects of NASH, whether steatosis, necroinflammation, fibrosis. But what is really good is that they also tested versus the mono or dual PPAR agonists separately, which some of them are in development for NASH as well. And it shows that it gives better improvement because you cover all three subtypes of PPAR receptors. So this type of preclinical studies, we find them very important as far as they relate to innovative molecules or to molecules that are already in development. But of course, we're not all about pharmacological trials, and we also try to look at the other aspects of NASH management. This is an article published in 2019 that has shown a large database in 10 countries, almost 500,000 people, that physical exercise decreases the risk of hepatobiliary cancers, in particular hepatobiliary carcinoma. Very good study that has shown that, in particular, waist circumference and increased BMI explain most of the association between physical activity and HCC. So if you do sports and gymnastics and you reduce waist circumference and BMI, you have less chances to develop HCC. Now, this is not the trial I want to comment here, but what I want to comment here is, again, a commitment of the journal to look at high quality, both clinical and preclinical studies among the same aspects. And this is an example here. You can see on the left part of the slide, a very large study from two large cohorts in the United States, which are the nurses health study and the health professional follow-ups study, almost 500,000 patients that were followed here. And you can see that it demonstrates two things. First of all, that BMI and waist circumference are associated with liver-related mortality. And second is that physical exercise in a dose-dependent fashion reduces liver-related mortality. And this sort of confirmation for large databases are very important because they show that definitely the impact that physical exercise can have. But then you have to understand the mechanism. And this is why it is important to publish articles like this one by Jeff Farrell's group in Australia that has shown that if you put mice that are diabetic and have a mutation that favors development of diabetes, but you put them on a treadmill, they'll end up having less liver cancer, although you challenge them with a carcinogen. And they went further to understand the mechanism. This study did not show that the protective impact goes through AMPK activation, or through the mTOR activation, but instead they have shown that it goes through an inhibition of JNK. JNK is an important transcription factor that is activated by ER stress in conditions of lipotoxicity, and that can promote fibrosis and liver cancer. And it's important to notice because now we have JNK inhibitors that are in the clinic, at least in human trials. So I will end up with, oh no, I'm not going to end up, this is just the middle. So diagnostic and clinical advances, very important also aspect of our interest. This is a very comprehensive study that I would like to show you because it kind of gives you the new standard of publication in high impact journals. This is a study on Mendelian randomization, trying to understand whether steatosis increase the risk of diabetes and obesity, and also the other way around, whether diabetes and obesity increase the risk of steatosis. And they looked at the UK Biobank, first looking at genetic predictors of NASH and whether that increases the risk of diabetes, and then second looking at whether diabetes and obesity increase the risk of NASH. So looking at the bidirectional interaction between the two using a very large database and the Mendelian randomization approach, which is of course supposedly independent of all other biases. And they end up identifying, first of all, demonstrating the relationship between these comorbidities, but also identifying different types of NASH, some that are genetically determined and some that are metabolically determined, and which do not have the same consequences in terms of overall associations and metabolic health. And this is very well defined in the paper. So this is a huge amount of work with very complex bioinformatic methodology, but it's only actually half of the paper, because once this has been shown, the authors went on to test the hypothesis in an animal model by creating transgenic mice that are carriers of the PNPLA3 mutations, which, as you know, is the main gene involved in NASH. And they have shown in this particular study what are the mechanisms that explains the relationship between the genetic NAFLD, the expression of some of the genes, and the subsequent occurrence of diabetes. And they have identified a type of diabetes, which is late onset diabetes in adults, that is less dependent on insulin resistance, more dependent on insulin secretion, and that happens to be occurring in patients that had genetic NASH. So very complex paper that show you how much work is now necessary to publish in top articles. Then we also have some papers on biomarkers, because this is a hot field. I'd like to mention here the Swedish studies, very large database, nationwide registries, people that are followed for a long time, and they looked whether, crucial question, whether non-invasive markers can predict in time, longitudinally, the appearance of liver-related death. And they've looked at the different changes between categories, low, high, high, low, etc., in FIB4, which is one of the most important markers. Another example is a meta-analysis. So we're not very keen on meta-analysis. However, important topics and very large databases are, of course, important to analyze with this methodology. And this is an example from the Litmus Consortium, which is a very large academia pharma consortium that is devoted to the study of non-invasive tests in NASH in particular. And they came up with this large meta-analysis of ELF, which is something that has been published now 14 years ago. But a lot of studies have accumulated, and they were able to do this with the highest possible methodological rigor. And you can read the paper. Very important information if you want to use ELF in different contexts of use and in populations that are either low risk or high risk of NASH. Results are not at all the same, and people need to be aware of that, and this is what this article is about. I would finish with some other things that I particularly appreciate about autoimmune and genetic diseases. Here again, well, there's less, therapeutic development in this area, but still there are some very interesting things going on, and we're trying to cover these. This is, for instance, an international study of Obeticolic acid, an FXR agonist, for primary sclerosing cholangitis. And this study has been published in the journal Hepatology, and you can see it brings important results about a early and sustained reduction in phosphatase alkaline in people with primary sclerosing cholangitis. And this is the basis for a further, hopefully another larger trial that will be initiated. Another important trial in the field of autoimmune diseases is on UDCA, very old agent, very good friend of hepatologists. And this study in particular looks at whether giving UDCA after liver transplantation has an impact on recurrence, on graft loss or on mortality, either global or hepatic. And very, very big investigator-initiated study you can see here from the Global PBC Study Group that has demonstrated that patients transplanted for primary biliary cholangitis should have AUDC treatment after the liver transplant because it has many beneficial effects, as you can see on this slide. But also, our journal is tries also to provide important educational advances beyond the original articles. And this is an example that I wanted to show to you because it comes from the most reputable consortium that studies autoimmune hepatitis, is the International Autoimmune Hepatitis Group. And this paper details a consensual recommendation of what should be the second or the third line therapy for autoimmune hepatitis. And if you read this paper here, very well developed, very well cited, all the important papers are being analyzed here, and a summary of the recommendation is provided. And as you can see here, very complex scenarios that fortunately the literature that has been reviewed provides some guidance on how to treat these patients. But of course, this needs to be put into authoritative recommendations, and this is what this paper does. So everybody needs to read and study that, and we're very proud that this article was published in our journal. But then you go into some other type of diseases which are very rare, but very important for the hepatologist. And of course, this is not something that will tremendously increase the impact factor. However, I think that it provides an important educational tool for people around the world who want to educate themselves in more rare disease in hepatology, and therefore I think those are worth publishing. This is a very nice study on the different variants in the MDR3 gene and how this can induce cholestatic liver disease in adults. And you can see here this review is very well documented, both with diagrams, but also with real patients, clinical data, and it tells you all about progressive familial intrahepatic cholestasis, or about other diseases such as the LPAC syndrome. And finally, another very rare disease, which is the largest registry in the world on bile salt export pump deficiency. This again has been published in the Journal of Hepatology, and this being the largest registry, it has the power to understand and detect genotypic phenotypic correlations. And what this study has shown is that some genotypes, particularly the BSP3 mutations, are the ones that are most associated with the loss of the native liver and with the development of hepatocellular carcinoma. And therefore, this study provides important information of who should be screened for hepatocellular carcinoma depending on what mutations are there, and also important information on who should have biliary diversion surgically performed, which particular genotypes respond better to that, and is that a way that can help the patient keep his native liver and not go to liver transplantation. So because of the power of this registry, important differences were seen based on the genotype, and therefore we can adapt treatment and monitoring of these patients. So I think I should stop here. I tried to highlight not only the important papers that were published, but also a little bit of what we think our mission is in terms of providing the most accurate, the most novel and cutting edge information, at least in these areas of hepatology. Thank you.
Thank you so much, Vlad. Very impressive review of the engagement of the journal in NAFLD. And now it's my great pleasure to hand over the mic to my co-moderator, Professor Masao Omata. Masao?
Yes, Massimo, how are you? Yeah, Saturday night, 10 p.m., almost 10 o'clock. So I'm very glad to introduce Stefan Chang from Hong Kong. He's an associate professor of the clinical oncology and Chinese universities. And he's been in this for many years, and tonight he will touch upon the hepatocellular carcinoma. Stefan Chang, please.
Yeah, thank you, Professor Omata. Pleasure today to share with you my choice about the topic of liver cancer from the angle of general hepatology. I would also like to thank the APASL and also Dr. Paolo for choosing me to present. So in the next 18 minutes, I shall also try to go over some of the publications in the journal of hepatology related to the liver cancer. So in 2020, so I will go through the three magic figure, namely the 4, 3, and the 1. 4 is the 4 original research papers. 3 is the 3 review articles that I will briefly go over, and also the finally 1 editorial. So just about the background. For liver cancer, we know there have been many advances in the treatment of liver cancer. Today, I shall try to go over 3 aspects which I think is important in the advancement. One is that we know we have been, there are many local treatment for liver cancer, but actually there's some emerging role of some existing treatment. And this is why there should be some paper that which may consolidate the role of the local treatment. And of course, nowadays, in terms of the systemic therapy, there have been a lot of advances in immunotherapy, especially the immune checkpoint inhibitors. And therefore, apart from publishing more clinical trials, another important role is to optimize the uses and also advance the knowledge on the use of immunotherapy. Finally, we should have some more novel treatment. And apart from the TKI or the immunotherapy, we also welcome some paper which provides some of the out-of-box novel mechanism to guide future development of the treatment for liver cancer. So about the 4 original research papers. The first paper I chose was a paper titled Stereotactic Body Radiation Therapy versus Radiofrequency Ablation in Asian patients with HCC. The background about the study is that there have been lack of RCT comparing the SBRT to RFA for early stage HCC. And there have been a number of previous publications, mainly on the retrospective comparative studies between these 2 treatment modalities. But these studies are limited by small sample size or relatively short follow-up, or usually sometimes a single center study. Even there's a national database study, there have been lack of details on the pattern of the recurrences. So the feature about this study is, first of all, it's a multi-center study in Asia with a reasonably long follow-up times. And also more importantly, the sample size is a very robust study with a sample size of over 2,000 of the patients with mainly the RFA treatment and the SBRT. So what were the key results? The key result was that when you look at the recurrence rate of the SBRT versus RFA, you can see that actually the SBRT is associated generally with a lower recurrence rate as compared to the RFA. And this remained after matching with the propensity score matching. And when you look at the survival, apart from the recurrence, you can see that initially, before the matching, the RFA seems to have a slightly better outcome than SBRT. But this is mainly because the SBRT is biased with more patients with more advanced disease. And after the propensity score matching, you can see basically differences disappeared. And the only prognostic factor was the Child-Pugh class, which is not surprising in HCC patients. And what's more important from this study is about the clinical applications. What is really subgroup of patient that is benefited from the RT instead of the standard treatment RFA? And the study tried to look at the details about the location and also the sizes of the tumor. And you can see that most of the benefit of the SBRT in terms of local recurrence comes from the subgroup of patients with a subphrenic tumor, i.e. those patients with the tumor at the subphrenic or at the dome of the liver. And also the size, this remained, the SBRT remained better than the RFA, regardless of the size, smaller or larger than 3 centimeters. So what were the clinical implications of this paper? In the daily multi-tumor board, are we going to replace the radiofrequency ablation by RT? Probably no, because we still don't have an RCT to directly compare these 2 treatment modalities. But in case we really come across some tumor with a location which is difficult to be treated with RFA, like at the dome or subcapsular or subphrenic tumor, perhaps this study provides a evidence that SBRT is a valid treatment for this group of the patients. So the second paper I chose was the association of the inflammatory biomarkers with clinical outcomes in nivolumab-treated patients with advanced HCC. The background about this study is that we know the anti-PD-1 monotherapy is associated with response in 10 to 15% of patients. But actually, there have been very few data on the predictive biomarker for patient selection, mainly because there have been lack of prospective study, and also most of the studies fail to have some paired treatment and also tumor samples for analysis. So the summary about the methodology about the design is that it's come from exploratory analysis of a CheckMate 040, in which the patients, there have been some collection of pre and post-treatment blood samples, and also some pre-treatment tumor biopsies. And then there's also been multifaceted biomarker analysis, especially including those inflammatory gene markers, and so some T cell markers and the macrophage markers. And of course, in this trial, there have been two group patients, one belonged to the responders and the other to be belonging to the non-responders, and which enable the analysis. So for this study, there have been a large number of markers being evaluated. For example, for tissues, the PD-L1 IHC, and also there have been some inflammatory gene expression on those fresh tumor. And also there have been an evaluation of a number of serum markers, including alpha-fetoprotein, the viral load, the neutrophil lymphocyte ratio, and other cell count markers. So the key result about this study was that although there's a trend favoring CR or SD as compared to PD in those patients with a PD-L1 positivity, but the take-home message of this paper is that even in a PD-L1 negative patient, i.e. those with lower than 1%, you still see patients with complete response. You also see patients with partial responses. And therefore, PD-L1 expression is unlikely to be a binary marker that tells us to give or not to give the checkpoint inhibitors to the patient. What's more interesting from this study is that they have done some gene profiling, RNA sequencing on some inflammatory gene expression, but you can see the number is relatively small because not many patients are able to provide the fresh tumor samples. But even with this relatively small sample size, you can see that actually there's a trend that those patients with high expression of inflammatory genes tend to have better responses, and also those patients with higher levels of the inflammatory gene signature have a better outcomes, seem to suggesting that maybe in the future we need a collection of the biomarkers to get the PD-L1 to help us select the patients. So what is the clinical implication of these patients? Nowadays, there's no doubt that we see a number of patients with very good and durable response from the anti-PD-1. In terms of the patient selection, I think this study provided the most robust biomarker analysis for anti-PD-1 in the prospective setting at this moment. And also, this study suggested that if we really want more robust analysis, fresh tumor biopsies is essential during the conduct of the clinical trial. And also, PD-L1 expression alone is inadequate to help us select the patient for anti-PD-1. And a multi-marker panel, either from the tissue or blood, is probably required in the future. The third paper, also about immunotherapy, is about a phenomenon of a hyperprogressive disease. Hyperprogressive disease is a very unique pattern of progression, which is usually for the patient when they were started some treatment. Before the treatment, the patient has some progression rate. When after treatment, the patient may also have progression. But hyperprogression refers to a phenomenon that some patients, they actually have an accelerated, unexpected worsening of disease after the starting of the treatment. So actually, this phenomenon is quite unique to patients with immunotherapy. For example, it has been described in the non-small cell lung cancer, around 8 to 30%, melanoma, gastric cancer, and head and neck cancers. Is it happening in HCC? In the past, people used to think probably it's very rare because we don't see a lot of very aggressive progression after immunotherapy. But this may be biased because we usually don't have a record of the previous progression rate before the starting the immunotherapy. So this study actually is very tedious study. The group tried to look at the time 8 weeks before starting the immunotherapy, and then look at the rate of progression. And then after starting the immunotherapy, they also measured and documented the rate of progression. They also evaluated a number of other tumor markers like the alpha-fetoprotein. So they came up with these key results. Basically, these is the rate of the progression in terms of a tumor growth kinetics or tumor growth rate or absolute tumor growth rate change. Basically, if the tumor patient with progression to the left of the threshold is just a natural progression. If the patient have a progression rate on the right side of the threshold, is a kind of a hyper progression, that's accelerated progression. So you can see that if the patient was put on supportive care in the second line setting or the regorafenib, the VEGF inhibitor, actually none of them experienced hyper progression. All of them experienced natural progression similar to what they have been started the treatment before. But as you can see, once the patient will started the anti-PD-1, nivolumab in this case, a number of patients, actually, they have a hyper progression after starting the treatment. And around 15%, according to this study, we reached these hyper progression. And what's more important or clinical relevant is that you can see those patients with hyper progression, they have extremely poor prognosis with a survival rate, survival time shorter than 4 months in most of them, and only lower than 10% of them were able to receive subsequent line of therapy. So basically, once the patient develop hyperprogression, they have extremely poor prognosis, and most of them are not able to survive long enough or fit enough to receive a subsequent line of therapy. How to predict it? This study have tried to look at done some multivariable analysis, and they seem to identify the patient with high neutrophil lymphocyte ratio tend to be associated with this hyperprogression, and also those patients with high NLR also tend to have a very poor prognosis. So what were the implications? I think the clinical implication is that, okay, when we started the immunotherapy for a patient, certainly we should tell the patient there's a chance of very good response and durable response, but also there's also a chance that they may not have response or sometimes even have a hyperprogression. And in the future, we should probably look at the combination. Why? Because when you look at the Keynote 240, the pembro versus placebo, or the checkmate 459, nivolumab versus sorafenib, you can see initially, actually the curves fail, the nivolumab or the pembrolizumab arms fail to separate from the placebo or the comparator arm. We don't know exact reason. One of the reasons may be there are certainly some responders to the immunotherapy, but this may be offset by the hyperprogressors who die in the early course of the disease. And this exactly the curve. What we want now is when we have the combination with the anti-VEGFR, the bevacizumab and the TKI, you can see the curve separate very early on. Maybe when we combine the VEGFR antibody or TKI, we can actually offset, reduce the chance of hyperprogression. The last paper I would like to highlight is about this. It's about a laboratory study. It's on the thyroid hormone, which could inhibit the growth of the HCC via induction of the differentiation and the metabolic reprogramming. The background about this study is that actually more than 10 years ago, it has been already observed that patients with hypothyroidism actually was present in a number of patients with HCC, in particular, those patients with cryptogenic cirrhosis, which nowadays we know probably related to the nephro. And also there have been some preclinical studies suggesting that when the liver animal model treated with the thyroxine, actually we could reduce the hepatic steatosis. And this study further tried to evaluate whether the T3 treatment could be a treatment modality for HCC. I won't go into too much details. The summary is that it has been shown that if the animal, the orthotopic model, been treated with T3, actually it could lead to regression of HCC, and even especially for those patients with very poorly differentiated HCC. And also, actually, even with T3 withdrawal, these anti-cancer effects seem to persist afterwards, suggesting there have been some intrinsic genetic changes. And also, when they look at the heat map, actually, the T3 could induce some metabolic changes in the liver model. So what were the clinical implications? The implication is, apart from TKI and ICI, which a lot of companies and a lot of investigators are working on, could this thyroxine be a treatment for HCC? Probably in the past, the answer is no, because we know the T3 treatment is associated with a lot of toxicity, especially the cardiotoxicity. But nowadays we know we have more safer form of the TR-beta analog. Actually, some of these has already been tested in the Nash or some of the metabolic diseases. Could this also be kind of treatment for the liver cancer? I think this paper could provide more evidence that we should move towards this direction as a new treatment for our patients, especially those patients with nephro-related HCC. The second part is very brief. It's about the review article. For your information, the Journal of Hepatology, especially liver cancer part, we also aim to provide some of the updated information for both education and also sharing of some of the practice guidelines or guidance for the HCC world. So in the 2020, we have 12 review articles, mainly on the liver cancer, different treatment modality, and also some of the biliary tract cancers. I would say all of them are worthy for reading if you are interested in the topic. But if you really ask me to choose, I would pick 3 for you. The first is Advances on the Molecular Classification and Precision Oncology in HCC, published by European colleagues. I think I read these articles, and it's actually include a lot of updated information about the novel molecular classification. The second one is about the diagnosis and management of toxicities of immune checkpoint inhibitors in HCC. We know there have been a lot of guidelines for the management of toxicity related to immune checkpoint inhibitors. But for HCC, who usually have a lot of cirrhosis and comorbid liver problems, actually this guidance provides more specific guidance on those patients and also provide more differential diagnosis when we manage this group of special patients. The third paper is actually not related to liver, but related to the biliary tract cancer. If you're interested in the management or advances in the treatment of cholangiocarcinoma, this article is really the one you should read because it really provides very succinct, concise, and up-to-date information about the current development and the future direction. So the last one is about the editorial. This editorial is not about liver. It's actually something, when you read the editorial, you can learn something beyond the liver. For example, this is one example. This is the editorial written by Dr. Paolo Angeli when he started his leadership for the Journal of Hepatology. When you really read the details of this article, you can learn a lot of things that you have never thought of. For example, you can learn that when Dr. Paolo traveled to Asia, actually it's not that easy for him to get a visa to China. So actually, I don't know about that, but I can assure you that when you travel to Hong Kong, you shouldn't have too many problems. And the second thing you can learn is that you actually can learn some European cultures when Dr. Paolo tried to describe 2 important statements or diplomas about from Italy, which when you try to learn, you can actually appreciate the culture of the Italy. And finally, you can also learn some leadership spirit in the journal, which I'm experiencing now. So this is my last slide. Sometimes I get email, sometimes I get asked by my colleagues how to publish in Journal of Hepatology. I don't have a magic answer, but today I've chosen the 4 papers in the liver cancer. I think these are some of the things that attract us to make the decision. For example, if you are touching on some already studied topic like RT versus RFA, you need something more special. For example, you need robust sample size, and also you need some details. For example, this study, they're featured by the availability of the data on the local progression. If you're going to publish on some post hoc analysis or exploratory works on prospective clinical trials, you need some multifaceted biomarker analysis on those papers that really is important. If you're going to study on some less studied topic, for example, hyperprogression, perhaps you don't need very large sample size, but you need a very stringent and detailed methodology to prove that the phenomenon or the concept that you're showing is correct. And finally, if you're going to have some laboratory works on some known concept, for example, T3 treatment HCC, you need to provide some novel translational angle. I think this will probably improve the paper and give you a higher chance of being accepted in the journal. So thank you very much for your attention.
Thank you very much, Stefan. Very well summarized articles from a journal Hepatology. I think there was a tremendous progress for the treatment of hepatocellular carcinoma, in particular TKI and IO immune checkpoint inhibitors in this area. So I think we have to progress to the next speaker, Gane from Asia, also southern part of Asia. Gane is very well known for the pivotal studies in international consortium. And then today he will touch upon the viral hepatitis. Gane, please.
Thank you, Massimo. Can you see my slides?
Very well.
Yeah, thank you. Well, it's my privilege tonight or this morning to talk to you on the best papers in Journal of Hepatology and Viral Hepatitis. I've really had the pleasure of joining the editorial board at the beginning of this year. Some of the papers I will refer to are from 2019. And briefly, the agenda will be in viral hepatitis, talking about hepatitis C, about hepatitis B, and I'll finish by talking about another virus, and no prizes for guessing which one. Now, we've already heard about the Nobel Prize this year for the discovery and the characterization of hepatitis C, which really led to a huge advance in understanding and eventually therapies for this previously condition with high morbidity and mortality. And so most of the research for hepatitis C in the journal has been looking at, certainly of the trials, has been moving into the real world to look at the results of the drugs which are now approved and looking at special populations. If we look at the latest, I guess, kid on the block, and that is glecaprevir/prabenzisvir or Mavorite. There have been two excellent real world studies published recently in the journal. The first was a multi-center Italian study looking at over 700 patients treated in the real world with 8 to 16 weeks, depending on what was in the label at the time the study was performed. And you can see very high cure rates in the real world, equal to that seen in the clinical trials, and very safe and well tolerated. And this year, there was a much larger meta-analysis of real world experiences from 18 large series. Over 12,500 patients treated with glecaprevir/prabenzisvir. This is truly an enormous real-world experience. And again, cure rates similar to that in clinical trials. Over 98% of patients cured with no impact of genotype or cirrhosis in the real-world experience. And again, very well tolerated with few serious adverse events and even less discontinuations. And really, these studies, I think, have clearly shown us that this particular combination is safe and effective in the real world. The efficacy is maintained now in what was previously very difficult to treat populations. And really, this combination is ideally suited for community-based elimination strategies. So this is our first-line treatment. What about retreatment of DAA failures? And again, the journal has published two important real-world studies looking at the triplet from Gilead, sofosbuvir, velpatasvir, voxeloprevir, in patients who have failed DAAs, which included an NS5A inhibitor. One is a Spanish multi-center study and one is an Italian multi-center study. These are very similar experiences, as you'd expect, in two Western European countries. Reasonable numbers of DAA failures, and most of them had NS5A resistance, and around a quarter to a third had, in addition, NS3A resistance. So many patients had dual resistance at the time of retreatment. And the results are very similar. In the Spanish multi-center study, 95% of DAA failures were cured with this triplet. In this study, the predictor was genotype 3, and the 80% of genotype 3s were cured with retreatment, compared to 99% if you put together all the non-3 genotypes. In the other study, very high cure rates, but in this study, genotype 3 was not a predictor, and the only predictors were cirrhosis or the presence of liver cancer at the time of retreatment. And that has been, I guess, a recurring theme in other experiences. It's important to note that in neither of these real-world studies was baseline resistance-associated substitutions associated with failure of retreatment. Again, this is a very well-tolerated regimen in compensated patients. And really, this told us that retreatment of DAA failures with soft Valvox in the real world, similar results to clinical trials. Genotype 3 cirrhotics who have already failed a DAA regimen appear to be a more difficult to treat group. And I think in this, we're looking at other regimens such as adding ribavirin or using the alternative triplet of sofosbuvir plus glecaprevir preventosvir. And I think one thing which has come out of the real world studies, as was in the registration studies from Gilead, is that in the patients who do, the few patients who do fail retreatment, they do so without the evolution of new RASs. And what that tells us is you could retreat them again for a third time with the same regimen, but you probably want to add ribavirin or retreat for longer. And I think that's important. You're not selecting new RASs by retreating DAA failures. The other important study to come out this year was a further simplification in treatment of our cirrhotic population. Those real-world experiences, cirrhotics got 12 weeks of treatment with GLP-1. In this is a phase 3b study from AbbVie. 343 cirrhotic patients who were treatment naive were retreated with only 8 weeks of glecaprevir preventosvir, and that really showed that 8 weeks was sufficient in cirrhotics, provided they were treatment naive, and it didn't matter what genotype they were. And if you look at the per protocol or modified to intent, overall 99.7% of patients who took the drug as prescribed achieved SVR. There was only one single virologic failure documented across the 343 patients treated in this phase 3 study. And I think having an 8-week regimen for all compensated patients who are treatment naive really further simplifies this treatment pathway and makes it ideal for community prescribing, on the assumption, however, that all cirrhotics will be subsequently followed up in secondary care for HCC. But I do think for treatment naive patients, this is the final piece of evidence which tells us that we can treat patients without the need for genotyping first time around. I should point out that this year, APASL has published the next, and what I would think is probably the final recommendations on the treatment for hepatitis C. And these can be accessed online through the APASL website or downloaded from JHEP. And this is the latest and best recommendations for a guide to how to treat patients who are treatment naive and treatment experienced with DAA therapy. So looking beyond a cure, what does cure mean in terms of long-term outcome? And there are 3 important studies. The first is looking at whether DAAs will reduce mortality. Remember the Cochrane analysis a couple of years ago, which declared that there's no evidence that it did. Well, clearly there's good evidence now. This is a huge database from the Veterans Affairs. It's called the eChive study. And you can see they looked at over 50,000 patients treated with DAAs, compared them to untreated patients and non-infected control. So huge numbers in this study. And you can see that SVR was associated with a significant reduction in liver-related mortality and in non-liver-related mortality and overall mortality compared to patients who didn't achieve an SVR. And these survival curves reiterate that there's an ongoing benefit in terms of all-cause mortality and liver-related mortality in patients who achieved SVR compared to those who were treated but failed treatment, and those numbers are very small, as this was a DAA study, and compared to untreated patients. So a 14-fold reduction in overall mortality, a 13-fold reduction in liver-related mortality, and a 6-fold reduction in non-liver mortality, most likely related to a reduction in cardiovascular or diabetes-related deaths, although this data could not be gleaned from this particular study. there was an interesting observation that some patients who didn't achieve SVR were associated with reduced mortality, even with DAA therapy, and that has yet to be further explored. What about reversing liver failure? Will DAAs rescue patients from the waiting list and reduce the demand for liver transplantation? We've seen data from the SOLAR studies from Gilead and other large series, including the big Italian study published in this journal some year in 2016. This is from the Target collaboration. They looked at over 640 patients who had advanced cirrhosis, who were treated with DAAs, very high SVR rates, despite a median MELD of 12 and up to 39. So 91% achieved SVR. They looked at short-term benefit. This is a change in MELD from baseline by SVR12. And these graphs look a wee bit like the SOLAR graphs, but the mean reduction in their study in the real world was a less than 1 point reduction in MELD, with only 24% of patients achieving a MELD reduction by more than 3 points, which is what we think is a clinically significant response. What about long-term? They followed patients up to a mean of 4 years post-SVR. And then the ongoing reduction in MELD was really quite mediocre, with a median MELD reduction of only 0.3 points. And only 29% of patients followed for 4 years post-treatment had a significant reduction of MELD by 3 points. So an absolute MELD of less than 10 was achieved in only a quarter of patients. And if patients started off with a MELD of more than 16, only 1% of those had a reduction to MELD, which we would think would be significantly reduced to well compensated. So this brings up again the question about what do you expect in long-term outcomes after SVR in our sickest patients? From this study, it looks as though 3/4 of patients are left with a MELD of greater than 10. And these are the patients they describe as MELD purgatory. And these are the patients we think have to be followed for evidence of decompensation and relisting for liver transplantation. And really, this sort of data and other data like this would suggest that the huge reduction we're seeing in demand for transplant for hepatitis C, both in Europe and in America, and now in Australasia, probably reflects largely treatment of compensated patients and prevention of decompensation or reduction in liver cancer, rather than rescue from the waiting list. The other vexing question is, do patients with severe portal hypertension remodel enough that their portal hypertension regresses following successful treatment? This study performed at the multiple centers in Spain, looked at 176 patients who had clinically significant portal hypertension with a hepatic event special gradient of greater than 10, and most greater than 16. And they looked at outcomes at baseline, SVR24, and SVR96, so 2 years after treatment. And they looked at whether you could correlate baseline and on-treatment HVPGs with subsequent long-term risk of decompensation and death. I think this is a very important study. First of all, it showed us that even at 2 years after treatment, over half the patients remain with clinically significant portal hypertension. And it's those patients who had the highest HVPGs at baseline, and I don't show you the data, but also at 2 years, who had the highest rate of decompensation and death. And they constructed a model where they looked at the HVPG at baseline and the presence of ascites as being particularly associated with poor outcomes. So this really, again, shows us that your sickest patients, the patients with the most severe portal hypertension, they're the ones who will have the least improvements after successful treatment. Only a quarter of them will have the reduction in HVPG may be as high as 24%, but more than half the patients will have persisting clinically significant portal hypertension at 2 years post-treatment. And this is associated with decompensation and death. And you can predict at baseline who's least likely to do well long-term. And this may be important for deciding who goes ahead and is listed for liver transplantation. This journal has been very important for advancing the assessment and management of patients with viral hepatitis being considered for kidney transplantation. And Philippe Mathurin's initial paper, I think, really set the scene for how we assess patients for kidney transplantation. If you recall, this was a case-matched study, and this was at a time in the 70s and early 80s where hepatitis B was common, 15% of renal transplants in France, and 30% had hepatitis C. And this study showed clearly that both hepatitis C infection and hepatitis B infection was associated with reduced survival post-kidney transplant. And this certainly guided my clinical practice for the next decade. The next study, again by Mathurin and others from France, has advanced the field further. And this is a huge study from all transplant centers in France. And it's a later era. So it's from 1993 to 2010. That's important. This is a time where we have nuke therapy for hepatitis B, and in the later part, DAAs for hepatitis C. You can see that the prevalence of hepatitis B and hepatitis C were much lower in this era, as we'd expect from the universal precautions in our dialysis centers. And what this follow-up study was to show was whether antiviral therapies we now have available had made a huge impact on outcomes after renal transplantation. The first thing they showed was that hepatitis B no longer impacted outcomes post-transplant. And this is, of course, because this era is conducted at the time when all patients with active hepatitis B were started on nuke therapy before transplant and continued post. But note that hepatitis C still had an adverse effect on outcome after kidney transplantation. And that was in viremic patients. And with the development of effective DAA therapy, that's gone away. And now patients who have hepatitis C and who have been effectively cured now have outcomes post-renal transplant as good as patients without chronic viral hepatitis. So we're in our era now today of safe and effective antiviral therapies for both hepatitis B and hepatitis C. Neither of these infections are regarded as contraindications to kidney transplant. And the KDIGO guidelines for renal transplantation have been updated to say that the only contraindications to isolated kidney transplant today are decompensation at the time of assessment or clinically significant portal hypertension. And those patients, of course, should be considered for dual transplant. We come back to Asia for the further update on what are the risks of hepatitis B reactivation in patients with hepatitis B, hepatitis C co-infection when they receive direct-acting antivirals for their hepatitis C. And I think the Taiwanese have provided us with the best data for this, and this is an updated study. Relatively small number, but 79 co-infected patients. Most were not on nukes when they had DAA therapy, and they used the same definitions as they used in the initial study for HBV reactivation and for clinical reactivation. And they looked at three outcomes. They looked at patients who achieved SVR with hepatitis B did not reactivate. They looked at patients who did reactivate, and they looked at patients who reactivated but then lost surface antigen. So as you'd say, a healthy reactivation. The rates of reactivation were higher than previously reported. 28% of patients had HBV reactivation as defined as a 1 log increase in DAAs or converting from negative to positive. But if you follow these patients for a year post-DAA therapy, if they weren't on nukes, 40% met the definition of HBV reactivation compared to only 8% in the control group. And the best predictor was a surface antigen titer at the time you started the DAA therapy. And if patients had a surface antigen titer of greater than 10, they had a greater than 50% rate of reactivation. And that was important because 6 patients decompensated and 2 actually died from the hepatitis B reactivation despite starting nuke therapy. They also noted, as I said, a significant rate of surface antigen clearance, and that went up to 10% in patients at 1 year post-EA therapy. And the best predictor again was surface antigen, but this time it was a low titer of less than 10. And of those patients, over a quarter lost surface antigen during that year of follow-up. So we've got further information really showing us that reactivation is something you need to watch for. It can occur in up to 40% of patients with co-infection during DAA therapy. And the authors recommend that if the surface antigen titer is greater than 10, or if the patient has cirrhosis, that nuke prophylaxis should be given to all those patients. Coming back to Asia, this of course is from the Hong Kong group, Grace's group at Chinese University of Hong Kong. Again, an important study which further shows us the benefits of functional cure and why we consider surface antigen loss is so important on treatment. Again, a huge study from the Hong Kong group, over 20,000 patients on long-term nukes were followed for a median of 5 years. Wonderful data sets. They divided patients up as to whether they had complete viral suppression or they did not have complete viral suppression. And you can see the vast majority did have complete viral suppression during treatment. And of those, just under 400 achieved surface antigen loss on nuke therapy. They were interested in looking at the benefits in terms of liver complications, in particular liver cancer. And if you look at the graph on the left, it shows us that DAA therapy, you can see what we know about the viral suppression reduces the rate of HCC by about 30 to 40%. But if you achieve surface antigen loss on nuke therapy, you reduce the incidence of HCC by 90% compared to those patients who are maintained on nukes. Important to note, there's no added benefit in terms of liver failure, and that's what we'd expect. Nuke suppression prevents liver failure. The added finding of surface antigen loss doesn't give you any benefit. So the benefit is entirely in the risk of developing liver cancer. And I think it's this data set really further emphasizes why we look at surface antigen loss as functional cure as the ultimate goal for our new therapies being developed for hepatitis B. So what else happened in 2020? There was another virus, of course. We had the SARS-CoV-2 virus. And this had, it was declared in a pandemic across the world in March. And it led to a number of questions for hepatologists and transplant physicians. And all of us had these questions, really, we wanted to look at. Was the liver cells, or were hepatocytes infected? And did that lead to liver dysfunction? Would chronic liver disease impact the outcome of our patients in our clinics? And of course, the effect of the pandemic, the ongoing effect on all of our efforts to achieve the WHO targets of viral elimination. And slightly different data from you. I just read this from each journal. These are the papers published on COVID in the Journal of Hepatology, and I have amalgamated letters and papers, because some of the more controversial papers got a lot of letters. And you can see there's a real boost in nothing much up until August, and then in September. And now we have a steady number of very selected, high quality COVID papers being published in the journal with a reasonable number now under consideration or in press. I'll just allude to a couple which I thought were most interesting. There was a very controversial paper published in the journal on suggesting that SARS-CoV-2 would infect hepatocytes. And that was reported in 2 patients with high transaminases, where they saw what they thought was evidence of direct cytopathicity within hepatocytes. This did trigger a number of letters to the journal. One of the questions were, how could this occur? The ACE2 receptor, the main way for cell entry, is rare on hepatocytes. It's found in cholangiocytes, but not hepatocytes. And subsequent papers have not confirmed evidence of replication within the hepatocyte or direct cytopathicity within the hepatocyte. So I think this is still unanswered. Liver dysfunction is common in COVID-19 in the disease, and it's much more common in hospitalized patients with COVID and those patients with severe COVID, including those admitted to ICU. And we've had a number of papers submitted to the journal looking at this from Asia and from Europe, looking at this association. The more severe the COVID disease, the higher the liver function test. And we know that that can be multifactorial. It can be due to the COVID. The severe hypoxemia and shock seen in multi-organ failure. We're knowing a lot more about the microthrombi seen with the COVID infection. And of course, an increasing number of drugs used to treat COVID, it can be associated with DILI. So this is very much multifactorial. I think there's clear evidence, however, that in patients with cirrhosis, they do have a markedly increased more mortality from SARS-CoV-2 infection. And this very important study from Ivaroni and others in Lombardy province, which really bore the brunt of the COVID pandemic early on in Europe. And this study, they looked at 50 patients with cirrhosis and SARS infection and compared it to about 400 patients hospitalized with cirrhosis and bacterial infection who did not have SARS-CoV-2. They showed that a quarter of patients with cirrhosis had a marked worsening in their liver function with MELD exceeding 15 points during hospitalization. 38% develops acute on chronic liver failure. And 34% had a 30-day mortality. And that's significantly higher than cirrhotic patients hospitalized for bacterial infection. So certainly there's good data here that patients with cirrhosis do worse with SARS-CoV-2 infection. And it's a baseline MELD infection is probably the best predictor of outcome. The higher the MELD score before the patient gets SARS-CoV-2 infection, the worse the survival. And this shows us quite clearly that 70% of patients with a MELD score of more than 15 had a 30-day mortality. So I think the evidence is clear. COVID-19 causes decompensation in patients with cirrhosis with a very high 30-day mortality, and that can be predicted by the baseline MELD or CLIF organ failure score. What about liver transplantation? I thought Patrizia may have taught about this, but I'll briefly, this is something which certainly we looked into this for our own center. 111 patients in liver transplant programs in Spain were documented with SARS-CoV-2 infection. Overall, 87% were hospitalized, 11% admitted to ICU, and 18% died. Now, this was no different from the matched population for the same age and same comorbidities such as renal dysfunction and diabetes. There's no doubt mortality was increased by comorbidities and age, but this was no different from a matched population. The important finding here was that mycophenolate, out of all the immunosuppression agents, was associated with a worse outcome, much higher progression to severe COVID, and as shown here, and it was associated with an increased mortality. And it was dose related. In patients who got 2 grams a day, which is our standard adult dose, 73% of them developed severe COVID. And the argument for this, the hypothesis is the synergistic detrimental effects on lymphocyte number and function seen with mycophenolate and the SARS-CoV-2 virus. So we think this is synergistic and increasing the worst outcome in patients with COVID. So the authors concluded that mortality, overall mortality, is not increased in our liver transplant recipients, but we should really consider stopping mycophenolate, certainly until our COVID patients have recovered before we reintroduce mycophenolate. Finally, there are a couple of papers on what was the interaction between COVID-19 and chronic viral hepatitis. And this Lenz Vaughan's group looked at what was the effect when patients received antiviral therapy. And what I concluded from this paper and some other letters to the journal was really Hep B and Hep C don't impact the outcome of COVID, and the absence of advanced liver disease is shown in previous studies. And COVID doesn't change the natural history of hepatitis B or hepatitis C. The indications for starting nukes in hepatitis B should be the same, but there are some drugs, such as high-dose steroids or tocilizumab, being used in ICU, which really should be covered by nuke prophylaxis. For hepatitis C, patients with COVID should be deferred treatment until we treat the hepatitis C, wait until they're fully recovered. There's no evidence that any of these drugs used to treat hepatitis B or hepatitis C have a beneficial effect on the SARS-CoV-2 infection in vitro or in vivo models. To me, I think the biggest impact on COVID-19 on hepatitis B and hepatitis C is on global elimination efforts. And this very clear paper published in the journal from Homi Razavi's group shows this. If we look at the impact COVID's had on closing down our clinics, preventing people from engaging with harm reduction, with opioid substitution, with needle exchange, has had a huge effect in terms of new infections no longer being prevented, almost 1 million new infections from a year of the COVID endemic. Increase in a marked reduction in new diagnoses because we're not testing patients in our high-risk populations, a marked reduction in treatment uptake, in particular in our high-risk populations, an increase in new infections because people are no longer accessing harm reduction, 72,000 excess mortality, 45,000 excess hepatoma. And so really, none of the regions based on this year of shutdown now would meet the 2030 WHO targets for reduction of incidence, treatment, or mortality. So we need to look at perhaps what can we get out of the COVID-19, what we can get out of telemedicine, what we can get out of public interest and public health. And I do think people are looking for opportunities, and I really congratulate the authors for these 3 publications in the journal, looking at how we can use the COVID-19 pandemic to really increase vaccination for hepatitis B, increase local responses to hepatitis C, including testing and linkage to care using telemedicine. So I think we need to take out of this what we can for looking for new opportunities to get back to our elimination strategies. So I'd like to finish now by thanking all the authors and really pay tribute to my mentor, Roger Williams, who has been certainly, his life has been celebrated this year at APASL and in the journal. And really, I would like a personal tribute to Roger for the help he gave me over my career. Thank you.
Thank you very much, Dr. Gane. I think all those COVID-19 infections, we are still treating the patient with hepatitis C and hepatocellular carcinoma. So I think, Shib, please introduce the last speaker.
It's a pleasure to introduce Professor Matias Avila, a very well-known figure in the field of hepatology from Barcelona University of Navarra, who has done extensive work in the gene therapy. And of course, the last paper I read with interest was on the alcohol in the gut, the round table or whatever. And today we have his pleasure to hear him on the publications in liver fibrosis and innovations in hepatology.
Right. First of all, thank you. I want to join my colleagues in thanking the APASL Steering Committee for this invitation. I am in charge of discussing some of the relevant work published in the journal on liver fibrosis and innovation in hepatology. I have to admit that it's been a difficult task because the choice was wide. And I just want to focus also for the sake of time on 3 examples of what we are looking for in the journal. We are interested in studies that address the deep mechanisms of disease, but also keep an eye on potential translational implications. And I think that these 3 examples may illustrate these points. The first one has been already alluded to by Professor Ratziu, and it comes from the US, from Gilead and other laboratories, and focuses on metabolic reprogramming. It is concentrated in the de novo lipogenesis and the role of acetyl-CoA carboxylase inhibition in the disruption of this metabolic reprogramming during stellate cell activation. Metabolic reprogramming is more and more recognized to be part of the disease progression in many cells and tissues. We are aware of glucose metabolic reprogramming and also more recently glutamine metabolic reprogramming in the context of liver fibrogenesis. There is also a major metabolic pathway that becomes reprogrammed during the progression of disease, and this is de novo lipogenesis. This is well recognized in the progression of NAFLD to NASH, where the activation of endogenous lipid synthesis in hepatocytes contributes to lipotoxicity. And this involves the activation of this pathway here that starting from acetyl-CoA, moves all the way to the synthesis of fatty acids and triglycerides. And here, in recent studies, it's been published in several journals that the inhibition of this de novo lipogenesis pathway by specific drugs targeting the key rate-limiting steps of this lipogenic pathway can have a positive impact on the progression of NAFLD, but also there was evidence that inhibiting antagonizing the low lipogenesis could also have an effect on the progression of liver fibrosis. So this study is the authors focus precisely on this topic. Would also de novo lipogenesis be taking part in liver fibrogenic cells, and would it contribute to their activation, and can we interfere with it with pharmacological tools? So the first thing these authors did was to test whether the inhibition of the key rate-limiting steps enzyme, acetyl-CoA carboxylase 1 and 2, which is the start point of de novo lipogenesis, or fatty acid synthase, a subsequent enzyme also important in this pathway, could prevent or could interfere with the fibrogenic activation of stellate cells. So using well-known and inhibitors of ACC or fatty acid synthase, some of them which are in clinical trials, these authors would demonstrate that the novel lipogenesis inhibition with these compounds was accompanied by inhibition or deactivation of the fibrogenic status of hepatic stellate cells, as you can see here by the procollagen production of these cells in response to the drugs. The authors went on to show in primary human hepatic stellate cells in culture from 4 different donors that the activation of these cells in response to TGF-beta could be markedly inhibited by the treatment with firsocostat, which is one drug inhibiting ACC. And this can be shown here by the expression of alpha-smooth muscle actin, collagen, and also by the reactivation of PPR gamma, a transcription factor which is downregulated during the fibrogenic activation of hepatic stellate cells, and is mechanistically linked, this downregulation, to the progression of the disease. They also shown that culture activation of primary rat stellate cells by plating to plastic surface could be also counteracted by an ACC inhibitor. Okay, from these, the authors wanted to explore the molecular mechanism that could be underlying these effects. And after showing that de novo lipogenesis was indeed inhibited by these compounds, they also focused on the metabolic reprogramming of glucose and mitochondrial respiration, which are also part of the effects that mediate TGF-beta induced fibrogenic activation. As you can see here, The glycolytic flux that is triggered by TGF-beta was markedly inhibited in the presence of ACC inhibitors. Also, looking at mitochondrial respiration, although this effect of TGF-beta is more modest, the inclusion in the culture medium of ACC inhibitor could downregulate potently mitochondrial respiration. These effects are summarized here. You can see that in response to TGF-beta, the stellate cell acquire an active energetic state, which is reverted by the inhibition of de novo lipogenesis. The ultimate mechanism of this connection between glycolysis, glucose metabolism, and de novo lipogenesis are not well understood, but the authors speculate that since de novo lipogenesis occurs downstream of glycolysis, the inhibition of de novo lipogenesis will lead to the accumulation of intermediates of this pathway, which will result in a negative feedback inhibition of the glycolytic flux, which is essential response in the activation of these cells by TGF-beta. So the authors then went on to provide some in vivo evidence of this effect that they have shown in culture cells. So they here, I just mentioned a couple of the experimental models that they use. They tested this inhibitor in a dietary model in rats, and chronic is a choline deficiency high-fat diet, in which the ACC inhibitor is administered once liver injury, fibrosis, and steatosis are present, and treatment goes on for 5 weeks. And as you can see in this picture, which summarizes the results, treatment with a pharmacological inhibitor of ACC resulted in a significant control of liver fibrosis, and also the regulation of liver injury and steatosis. Interestingly, although they validate these results in other models of fatty liver in mice, such as OB mice and dietary models, they go on to demonstrate that this inhibitory effect of ACC blockers on fibrosis may be extended to other models in which there is no associated fatty liver disease, such as the administration of diethylnitrosamine to rats, which induces liver injury, fibrosis, and also carcinogenesis. In this context, the administration of this ACC inhibitor also resulted in a profound remodeling and protection and inhibition of the progression of the disease. So with these and other results that are clearly presented in this study, the authors can claim that ACC inhibition is able to block the TGF-beta mediated fibrogenic activation of stellate cells, and that the inhibition of de novo lipogenesis is able to reverse the metabolic active energetic state that is characteristic of the pro-fibrogenic and activated phenotype of these cells. And on top of it, they propose that the mechanisms of hepatoprotection underlying the effects of ACC inhibition in the context of NAFLD, Nash, and fibrosis would be twofold. On one hand, the ACC inhibitor, as it has been previously demonstrated, would prevent lipotoxicity in hepatic parenchymal cells, in which it will increase also fatty acid oxidation and reduce lipogenesis. But on the other hand, and concomitantly, it would have a direct effect on the fibrogenic activation of hepatic stellate cells, which had not been previously recognized. Now, we move to the next study that also illustrates this work that we are encouraging in our journal, the identification of mechanisms of the disease and at the same time of potential therapeutic targets, and with this preclinical evidence for translational implications. In this case, this group coming from the Cleveland Clinic in the US, they address the role of IRAK4 kinase in ethanol-induced liver injury. IRAK4, as you can see in this scheme, is an intracellular mediator of signals that coming from the extracellular milieu in a context of inflammation, such as occurs in alcohol-induced liver disease, such as the hyperproduction of interleukin-1 beta, or the presence of toll-like receptor ligands like bacterial endotoxin, which is elevated, as we all know, in alcoholic patients. These extracellular inflammatory signals are transduced inside the cell through the MyD88 complex, in which IRAK4 is involved. Downstream of IRAK4, we have also IRAK1 is another component of this complex, which is activated and degraded. And then IRAK4 mediates the activation of several intracellular pathways, leading to the expression of inflammatory cytokines, chemokines, and also acute phase response reactants. In this context, the first approach that undertook these researchers was to demonstrate, to evaluate whether IRAK4 is activated in the liver of patients with alcoholic hepatitis. As you can see here in this very clear immunohistochemical assays, the hepatocytes from liver coming from patients with acute alcoholic hepatitis, they show a strong staining for the activated form of IRAK4, the phosphorylated form, and this is validated here at the Western blot level. And this response can be reproduced also in mouse models. As you can see here, the IRAK4 activations, also IRAK4 is also detected in the liver of chronic ethanol-fed mice, according to this scheme you see here at the termination point. And to gain insight into the mechanistic significance of this activation of these kinase, the authors implement a model of transgenic mice in which IRAK4 has been functionally eliminated through the introduction of a knock-in defective allele. So, taking advantage of this model, as you can see here, when these animals, these mice, are subjected to chronic ethanol feeding, the defective mice that don't have a functional IRAK4, they show clearly reduced levels of liver injury and also reduced level of fat accumulation, triglycerides in the liver parenchyma. Importantly, this response was accompanied by significant attenuation of inflammation in the liver tissue of these mice. Here you can see the comparison between wild type and IRAK4 defective mice in terms of the expression of inflammatory genes such as TNF-alpha, interleukin beta, interleukin 6, MCP1, comparing both wild type and IRAK4 defective mice when they are fed with an ethanol enriched diet. Interestingly, these mice also show reduced activation, reduced levels of acute phase reactants such as serum amyloid A1 protein. This observation is important and is relevant to the study because there are recent reports showing that SSA1 can contribute to the fibrogenic activation of hepatic stellate cells, and as the authors show in this study, SSA1 together with ethanol and inflammatory cytokines can also contribute to hepatocellular injury. Okay, according to the reduced expression of inflammatory mediators, these mice have reduced inflammatory infiltration and reduced numbers of Kupffer cells, activated Kupffer cells in their living parenchyma. And all this is accompanied by a reduced levels of hepatocellular injury, as shown here by the tunnel assay. Okay, one big issue in this context that the authors wanted to further analyze was, okay, IRAK4 can be expressed both in myeloid cells, but also in parenchymal cells and other cells in the liver parenchyma, such as hepatocytes. So in order to gain insight into which was the cell type where IRAK4 was playing a major role, or they implied experiments involving bone marrow transplant between wild type and IRAK4 defective mice. And as you can see here, according to the degree of liver injury, inflammation, and infiltration, these data show that the IRAK4 expressed in hepatocytes was the key cell type, was the key location where IRAK4 was mediated these noxious responses, while it was not essential in myeloid cells. And finally, to give it a push forward towards translationality of these observations, the authors implement two models of chronic and acute ethanol-induced liver injury. And as you can see here on the left-hand side, in the chronic model, after mice are fed for over 2 weeks with increasing amounts of ethanol, and they receive a treatment with an IRAK4 inhibitor that can be administered orally, the administration of this IRAK4 inhibitor resulted in a significant attenuation of liver injury and significant attenuation of fatty content in the liver. And these results could be also extrapolated in what the authors categorize as a preventive model, in which IRAK4 inhibitor is given before a high acute dose of ethanol in the so-known GAU binge model, as you can see here. Again, there was a significant protection against liver injury by IRAK4 inhibitor in this context. So, with all these data, the authors conclude that in alcohol-induced liver injury, IRAK4 activation, mainly importantly in the parenchymal cells, is going to trigger an inflammatory response involving both cytokines and chemokines that, together with acute phase reactants such as serum amyloid A1 protein, and in the presence of ethanol, may contribute to the onset and progression of liver injury and hepatocellular death. And therefore, they propose that the pharmacological inhibition of IRAK4 activity may be a new strategy to treat alcohol-related liver disease. We are all aware that there are several ongoing strategies trying to block interleukin-1 beta activity and receptor binding in alcohol-induced liver injury, and therefore this could be an alternative and highly effective approach to also obtain similar responses. So, and the last study that I selected today also is related to inflammation and liver disease and progression of liver fibrosis. And I like this study that comes from China because it identifies new protagonists, new players in the context of inflammation and the progression of disease. We are all very much aware of the role played by inflammatory cells like Kupffer cells and infiltrating monocytes in the production of cytokines and chemokines and growth factors such as TGF-beta, that is going to lead to the activation of hepatic stellate cells and the progression of fibrosis. But also we are very well acquainted with the role of chemokines, as illustrated here by CCL2. And CCL2 is a chemokine that is produced in injury. It's produced also from parenchymal cells and contributes to the recruitment of inflammatory cells from the blood circulation, and plays a fundamental role also on the activation of hepatic stellate cells. And there are inhibitors of CCL2 and CCL2 receptor and CCL5 interaction in clinical development for the control of progression of liver injury, liver fibrosis. Okay, these authors identify a new player in the context of CCL2 receptor signaling system. They previously identified this protein shown here, the PC3 cell-secreted microprotein, also known as PSMP. It was identified by this group a number of years ago as a new and high affinity ligand of the CCR2 receptor, which can also trigger intracellular signaling leading to cell activation and inflammation. The role of this mediator has been identified as a CCR2 ligand in other tissues and contexts in contributing to liver disease progression, but little was known about its contribution to liver injury and liver disease. So, sorry. the first thing these researchers did was to test for the presence, the expression of PSMP in clinical samples of coming from patients with different types of liver injury. And as you can see here in this broad collection of disease liver tissue samples from drug-induced liver disease, alcohol-related liver disease, viral infections, autoimmune conditions, etc., there is a consistent and reproducible hyperproduction of this PSMP protein in all these cases, while the levels of PSMP in healthy liver tissues was almost undetectable or very low. They go on to demonstrate that also in models of liver injury in mice, as illustrated here by the CCL4 model, but they include other models in their report. You can have also a marked induction of PSMP in liver parenchymal cells in the acute and also in the chronic context, and you can detect PSMP in circulation when you induce a liver injury. Okay, to fully address the real contribution of this new CCR2 receptor ligand in the context of chronic liver injury, the authors involved the use of PSMP knockout mice, which undergo different models of liver injury, chronic liver injury, CCL4, bile duct ligation, and other toxic models. And as you can see here, when you compare the degree of liver fibrosis in these mice with the wild-type animals, you see a clear reduction. And as a side comparison, you can see how CCR2 knockout mice, the receptor for PSMP and for CCL2 mice, they also show reduced level of fibrosis and injury. It is interesting because this illustrates the relevance of PSMP role in liver fibrosis progression, because in these mice, although at lower levels, you can still detect an induction of CCL2 in the liver of PSMP knockout mice. So it tells you that there is not a redundant role between CCL2 and PSMP in the activation of liver fibrosis and inflammation. And as you can see here, the production of inflammatory mediators, including TGF-beta, is reduced. From a mechanistic point of view, these authors are able to demonstrate that the infiltration of monocyte macrophages in the liver of PSMP knockout mice is significantly reduced compared to the wild-type animals. And through a series of in vitro experiments, they can show that it's not only the recruitment of the monocyte macrophages into the liver, but that PSMP can contribute to the polarization of macrophages towards the M1 phenotype, collaborating with other activators such as LPS and interferon gamma. Interestingly, the authors managed to demonstrate that not only monocyte macrophages are targets for PSMP, they also show that hepatic stellate cells can be activated by this CCR2 ligand. As you can see here, in vitro experiment shows that dose-dependently, the expression of activation-related genes such as alpha-smooth muscle actin or collagen or TGF-beta is induced by PSMP treatment of hepatic stellate cells, and that these responses are inhibited in the presence of a CCR2 antagonist. Interestingly, in vivo, the authors demonstrate that that lack of PSMP in the context of liver injury results in enhanced apoptosis of activated stellate cells. And finally, also providing interesting insights into the applicability of these preclinical observations, the authors provide clear results showing that when in the context of chronic liver injury induced by CCL4 to mice, when fibrosis is already developed and you treat these mice with neutralizing antibodies, 3D5 antibodies that can bind and neutralize the activity of PSMP, you can also prevent, you can also inhibit the progression of the disease, as you can see here, compared with the immunoglobulin control. And this is accompanied by reduced levels of liver injury. So all in all, in view of this observation, the authors can summarize the finding in a way that they demonstrate that PSMP is highly expressed in hepatocytes. They provide data, interesting data in vivo and in vitro, showing how PSMP expression can be triggered by damage-associated molecular patterns. And the production of PSMP is going to contribute to liver inflammation and fibrosis progression in mice. And it is also likely to happen in a human context, as the observation at the beginning of this presentation, showing that how human liver injury of almost any kind can trigger the expression of PSMP. And mechanistically, PSMP is going to trigger the recruitment of monocyte macrophages, promote their infiltration in the liver, and also is going to contribute to the activation of hepatic stellate cells, leading to fibrosis progression. Therefore, the administration of neutralizing antibodies towards PSMP could be a new strategy to prevent the progression of liver fibrosis, at least in mice. So I just want to finish here and thank you very much for your attention.
That was a masterly presentation, and we enjoyed every part of it, Matias. And it was so much learning and so much basic science, but very clearly presented. We're very delighted and grateful. May I now request our moderators to moderate? I just worked on behalf of Dr. Omata, who's a moderator. So maybe Paolo and Massimo and others could take over. I had a question with Dr. Ed Gane, and I passed it on to Dr. Paolo. In the chat box.
The question is, Ed, if in the study you mentioned by Burra et al., there are data whether ACC incidence decrease with or without reduction of portal hypertension, according to the reduction or not of portal hypertension. This is the question.
Right. So the Burra study was on decompensation. So the LENS study and portal hypertension, they didn't actually report on the rate of liver cancer. The excess mortality was due to decompensation in that group. But you'd expect, I agree, you'd expect in a patient population who have severe portal hypertension that they would have a higher rate of hepatocarcinogenesis. But certainly in the follow-up of 5 years, the excess mortality was due to decompensation. And some patients did get HCC, and some patients were transplanted for that.
Thank you very much.
Let me ask a question that from Japan. You know, in our experiences, particularly the Hep C, majority cases they develop cancer before they develop obvious portal hypertension. So the reduction of fibrosis, it's a remarkable reduction of cancers, but not necessarily related to the reduction of portal hypertension because the patient don't have it, obviously. So that's our experiences.
I mean, certainly, we see in the large numbers of patients who are cured with early hepatitis C cirrhosis. So in the many of the registration studies, cirrhotic studies, patients were only eligible if they didn't have severe portal hypertension, but they had cirrhosis, and they've continued to develop HCC after cure, albeit at a lower rate. And that's the data we're getting from the long-term follow-up data from the Gilead studies and now the AbbVie studies. So you're right that those patients are still getting development of liver cancer, but at a lower rate after SVR. So the question is, who do you stop surveillance in? I don't think yet we can accurately predict which patient after successful cure of hepatitis C should not be surveyed.
Let me answer the things too, because I keep following all the patients despite not much of the fibrosis for almost 5 years. And then recently we experienced a couple cases in that there is a reduction of fibrosis and there is no abnormal transaminase, but they still get the cancers. And then that's, I'm not sure whether that's really due to the Hep C infection or due to some other factors like, growing number of cases due to Nash. So actually, even though we eradicate the virus, I keep saying to the patient, you better come to my clinic. That's my situation.
Yeah, I think it's a perplexing question, Marcia. I mean, who do you discharge after successful treatment of the hepatitis C? And I think we do err on being more conservative. And I think patients who have bridging fibrosis, liver stiffness measurement above, say, 10, we would certainly keep in long-term surveillance. But there's no answer as to why non-cirrhotics.
Rental insurance covers all those fares, expenses covered by the government. So maybe the patient's happy to come just to like healthcare checkups. Then incidentally, we found the cancers, hepatocellular carcinoma among those. Very rare, but still continue to have the cancers.
Well, I echo with Professor Omata. In fact, most of these studies are registry studies. And one of the shortcomings of these studies are the investigators or the researchers are not the one who is seeing the patients themselves, and is all day based on the ICD codings and etc. And a lot of those studies, especially the hepatitis B and some of them hepatitis C, concerning the occurrence of HCCs, they never mentions about the stage of the HCC being diagnosed and how are they diagnosed. I mean, it is really by surveillance or really it's symptomatic. So I don't think that we have a very concrete answer to a lot of those questions if we do not allow the prospective studies like what Professor Omata suggested, that we really follow up the patient with the same protocol and the HCC is being detected according to the protocol. We can have surveillance programs, but then how are the HCC being detected? I mean, these are the detection problems. And without this, it is very difficult for us to understand and how we are going to optimize our management program for HCC surveillance for those patients.
Oh, there is another question from the audience to Professor Stephen Chan. What is the incidence of hyperprogression after nivolumab? Any predictors? And should we always have an antivascular endothelial growth factor with it?
Yeah,
Stefan.
Thank you, Professor Paolo. I think that this is very good questions. If you look at the paper published in the Journal of Hepatology, the incidence is around 15%. But we don't know whether this figure is really a figure for all patients, because the patients studied are mainly the second-line populations, i.e. they have all failed or become intolerant to sorafenib. So we believe these patients are usually more worse patients with more adverse features. If you try to look at the all populations, including the first line, third line, second line, perhaps the figure, my feeling is it may be a bit lower, but we don't have these figures. But I think these articles can serve as a starting for us to pay attention to this phenomenon, which we used to believe is not there. So about your questions, whether we should include the VEGF for every single patient, I think it's too early to say that. We do see patients who are responding to monotherapy. But if you want a more proportional patient being benefited from the drug, we have learned from the Atezo-Bev data that you probably need combination. But for individual patients, as like FDA has approved now, I think it's still justifiable to give the monotherapy. But just mind you, there's a potential phenomenon when you follow up the patient. About the predictor, for the paper, they look at a lot of other factors like alpha-fetoprotein, PIVKA2, tumor number, for example. They only were able to find the neutrophil lymphocyte ratio of higher than 5 or 6. So quite high NAR to be a potential predictor. But at this moment, we don't have a very reliable parameters. We certainly need more studies to look at this issue.
Thank you very much, Stefan. Please, Professor Dusheiko, you can.
So I had a question to Ed regarding the Yip and Grace Wong paper. Ed, it's interesting that in fully suppressed individuals on nukes, the loss of HBsAg did confer a better prognosis and I believe a lower rate of HCC in particular. So my question is, did it depend upon the age at which HBsAg was lost? Is it really a reflection of HBsAg loss at a younger age? And does that effect hold out if you lose HBs at a much older age? And secondly, could the explanation be that in those individuals, it's a reflection of loss of hepatocytes with a clonal lineage as a result of integrated viral genomes? Something's different about those who lost HBsAg in that excellent study, but we need to know what it is that made the difference.
Sure. I mean, they felt it was, although there was an association with the development of HCC, there was an association with age and gender. But there were only 2 patients in the several hundred who lost surface antigen who developed HCC, so they couldn't really look at that data, Jeff. I mean, I guess the question is why? Why do you get a marked, 90% reduction in the development of liver cancer in patients who lose surface antigen? Obviously, you have no ongoing necroinflammation, but you should have very little necroinflammation in the fully suppressed patients who are maintained on nukes. Whether it reflects a change in integrants in the hepatocytes, there's very interesting data emerging on the longer somebody stays on fully suppressive therapy, the lower the number of identifiable integrants or active integrants are found in the hepatocyte host DNA. So presumably the patients who clear surface antigen will have a very, very low rate of integrants. But I can't answer your question about whether it's specifically the age at which they lose surface antigen, because they don't report that in the paper. But we could go back to, or Grace maybe on the call, I think, Grace Wong, she may want to answer.
Thank you, Ed. There is another question for Stefan Chen. You mentioned the low and high dose of vascular endothelial growth factor. What is a good dose of anti-endothelial growth factor?
Thank you. I don't think I've mentioned about the dose of EGF, which none of the paper have addressed this topic. I think probably this question is referring to the atezolizumab, whereas for the bevacizumab, they use a relatively high dose, the 15 milligram per kg every 3 weeks together with atezolizumab. Many doctors are quite concerned about the toxicity, but if you look at the clinical trial of I50, it seems the bleeding and also those bowel perforation risk is not that high. They only observed few cases of grade 5 hemorrhage, while they don't see any other problems. But of course, one of the key factors about this clinical trial is all of the patients, thanks to the stringency of the protocol, require the baseline endoscopy to rule out those high-risk varices, and they make sure all of them have been treated. So going back to your questions, I don't think there are any data suggesting lower dose is good enough. Certainly, we need the post-marketing data, because some centers probably using a lower dose to see whether the efficacy is jeopardized at this point. But if I were you, I would still stick to the FDA approval or the European label of using a relatively high dose, 15 milligram per kg.
Thank you very much.
review in JAMA Oncology early this month. So I just was referring to that and concerned about the low dose being better. But I thought you'll have experience. Sorry, Paolo, I would, in the interest of time, I have asked one question which I have written, but I take your permission to ask the chief editor. The chief editor, Paolo, I have sent the question to you. Would you read it yourself and address it?
Yeah. You asked me the best 3 papers that we publish in the Journal of Hepatology. It is an impossible mission for me to select the 3 best papers we published last year. So I want to finish this excellent meeting saying thank you to APASL for this kind of invitation. I think that the excellent presentation of all the editors highlighted the mission, the content, and the methodology of work in the Journal of Hepatology. And so I will invite all our attendants and readers to continue to send their best paper to our journal that is really the journal of the international community in hepatology. And again, I wish all you a Merry Christmas, and I wish to meet you in person next year as soon as possible.
Thank you.
Thank you. Merry Christmas.
Thank you.
Bye-bye.
Thank you. Merry Christmas, everyone. Bye-bye, dear friends.
Bye, everyone. Bye-bye.
Bye. Thank you.
Bye-bye.